often you get involved. And our meeting's being recorded for those who
sorry.
That's okay. Thanks, Todd. So what we'll do is, Michael, you can start talking. Yap and I will monitor the chat, and Todd as well monitor the chat, and that's where the students or other people listening can put questions. That way you don't have to keep your eyes on both. I mean, if you're good at that, great. I know I'm not when I present, so it's always helpful to have the moderator kind of collecting questions to present. So you may go ahead and get started.
Great. Well, I thought that I would, I'll give us a brief introduction of myself and what I'm not going to talk about, and then we'll jump in to talk about what I'm going to talk about. So I am an alum of Emory. I did my MD and PhD there. My PhD was in PBE, although it was largely not really performed at Emory, but elsewhere. And now I'm an assistant professor of epidemiology and of immunology at the Harvard School of Public Health. I'm also the associate medical director in charge of molecular virology diagnostics at the Brigham and Women's Hospital, which is one of Harvard's teaching hospitals. I'm also an associate member of the Broad Institute of MIT and Harvard, where what will become relevant a bit later, I'm working on diagnostics for coronavirus. And so the original discussion that I was going to give was about the immune effects of measles, and at this point in time, nobody cares, so I'm not going to talk about that. But if you want to know more about that work, there's 2 papers in Science that one is from 2015 and one is from this past November 1st issue. You can read them, and they'll give you all the information that I would have given for the most part. So I thought that I would instead take this time to get people who might not be as familiar with coronavirus, both epidemiology and the beginnings of this, but also more to the point, sort of where we're at with testing and sort of what's going on in our communities across the United States and elsewhere. So I think everyone knows that coronavirus, of course, started in Hubei province and in Wuhan, and that was most likely based on sequencing data, particularly from Trevor Bedford's group doing the analyses and others. Does show that it started probably somewhere around in November. Was the earliest common ancestor in the jump into humans, and ultimately from that point in time, we've seen this pretty massive spread both across China first, and then into Singapore and South Korea and other nations nearby, and now we're seeing spread, of course, everywhere in the world. We're now seeing it pop up in South America and Latin America, where most likely it has been there for longer, but it was just not being tested for. And we're of course seeing it now in the United States. What doesn't appear to most people to be very high numbers, it's probably much higher than what we are measuring, because we are, of course, barely testing for the virus in the U.S. at the moment. And so I thought that one of the pieces that would be most pressing for people to just try to get an understanding of is the testing landscape and what has been really going on with that, because there's been a tremendous amount of media attention focused on testing, and I think that it's led to a lot of questions surrounding, what is going on here? Why isn't the U.S. testing, and who can be tested currently? So I'm going to talk a little bit about that, and then I thought that I would just allow people to ask some questions. We've been very engaged with modeling efforts surrounding the transmissibility of the virus and what populations are likely most apt to be transmitting this, and where this is likely, where we're seeing underreporting, for example. But I'll start with the testing bit and hopefully clarify some of it. So in the United States anyway, on January 31st, the CDC announced that that coronavirus is a public health emergency. And what this did the declaration of a public health emergency has allows some resources to be allocated towards approaches to mitigate transmission and prevent and contain the virus. And that's part of the idea. The other thing that got activated immediately was this requirement, which people have probably heard of at this point, called an emergency use authorization for the test. And that's often just described as EUA, emergency use authorization. So the activation of the emergency use authorization for the test put in place something which is supposed to be somewhat of a safeguard, particularly during a public health emergency, to ensure the quality of the tests that are being performed. And so, for example, the CDC put this in place. And what that means is that the normal functioning of laboratories, so normally, for example, I help run one of the laboratories at Brigham and Women's Hospital for diagnostics of viruses. Normally, we have very wide latitude to produce our own tests. If I want to make a new test for pneumococcus or for prostate antigen, whatever it might be, we are normally allowed to do that. And as long as we're only using that test on our own patients, we don't have to gain FDA approval to do so. We just have to do all the proper validations in-house and ensure that as medical directors, we feel that the test and the characteristics of the test are appropriate. The requirements of an emergency use authorization, on the other hand, essentially prohibited individual labs from being able to create what these tests are normally called, which are lab-developed tests. And instead, it essentially mandated that all lab-developed tests get approved by the FDA before being utilized for any patients, even just the patients that are in hospital. The reason is, at the beginning of an epidemic, or at least one of the reasons, is we don't want, there's a high cost to getting something wrong with these tests early on in an epidemic. So for something like Ebola, we certainly don't want to call somebody a positive when they're actually negative for Ebola in the United States. That would require a tremendous amount of mobilization of resources, panic, and everything that would ensue. We also wouldn't want to miss a case if we thought that it was Ebola and we get a false negative result. That would obviously be disastrous as well. And so ultimately what the EUA did was it said, okay, we want, if you think somebody has Ebola, we're just using that as an example for a moment, then send the specimen to the CDC, and the CDC will get the approved, will develop this, sorry, Lance is typing, Zoom may work more smoothly if you both mute sound and video. So the idea is that with the, if in an Ebola type of scenario, you'd send the sample to the CDC and they would have an FDA EUA approval in place for an assay that they develop and run, and that would ultimately provide verifiable and verified sort of characteristics of a test that we can trust as a country. And that's fine for something that's not going to spread widely in the United States. But what we saw with these very stringent requirements placed through the EUA mechanism in the US was there was this sort of backfire, if you will, where it led to a depletion of or just an insufficient number of tests being able to be performed across the country, because every lab was essentially had their hands tied, not knowing if they could actually produce the test and run it in their own hospital systems or not. And that actually led to quite a long delay. For example, in early February, as a laboratory director at Brigham, and in particular as an epidemiologist, the writing was on the wall that this virus was going to be certainly infecting people in Boston and the US. And so my inclination was to develop a test for it, a lab-developed test using normal PCR primers and probes, similar to the CDC protocol, for example. But there was a limitation for what we could do, and we didn't have any guidance of whether or not we would actually be able to run that test without going through an extraordinary laborious EUA approval with the FDA. These FDA approvals are normally designed for like manufacturers to produce tests that might go out to millions of people, for example, and they weren't initially designed for every other individual laboratory to have to fill them out because they were fairly onerous. So that brought us to the CDC kind of saying, okay, well, the CDC did get their FDA EUA approval for their test. They were able to run tests, and they sent all of these tests out to the state laboratories. And I think, as many people probably read in the news, the state laboratories were unable to validate the tests in their own hands, and the CDC ultimately had to sort of retract these initial test kits. Unfortunately, there was around a 2-week delay in getting any further notice from the CDC about what the next steps were going to be. And eventually it came down to still what seems to be a little bit obscured in the reasoning, but the third primer in that PCR set was kind of said to be a lost cause, if you will, and it was removed from the test because it was the one creating the problems. Whether that was truly primer design or contamination still remains a little bit up in the air. And I'm sure somebody has the answers somewhere. So that brought us to more or less the end of February, and finally the CDC was able to get these kits out to the state laboratories, and they were able to start ramping up testing, and there was a lot of hope, I think, for that. But what wasn't so much taken into serious consideration, or at least wasn't discussed widely in the media, perhaps because it wasn't evident, is that these tests are not high throughput tests. So if anyone's ever done PCR on a 96-well platform, you know that these are pretty low throughput assays. They take a few hours to run. You have to extract RNA manually using these small column kits usually, or magnetic beads. And ultimately, these are pretty slow. And so the state laboratories actually had quite a lot of trouble getting these tests set up for any capacity. And to this day, the state laboratories generally are averaging around 50 to 100 tests per day, which for a public health crisis like the one we're in is obviously extremely limiting. So given that with the recognition that there was truly just limited testing, both because of the delay, the EUA requirements, and then the difficulty in performing a lot of tests, the FDA has slowly started to really relax their requirements and who can get an EUA approval, to the point where now laboratories, high complexity CLIA laboratories, these are clinical certified laboratories, can now produce the tests and perform them on their own with a pretty clear and accelerated pathway to get FDA approval. It's still technically a requirement, but more or less the FDA has given the green light to say, create your primer set in-house, order it, do it exactly as the CDC one or the WHO, whatever you need to do, whatever you choose to do for your PCR set. And then just give us a call and let us know that you will be submitting an FDA EUA application soon, and we have streamlined the process. So that's been a really terrific move by the FDA. But still, people are seeing, okay, so now this has been a week or 2 or 2 weeks now that the FDA has really relaxed these regulations to allow laboratories like individual hospital labs at Emory and other places to do the test. But we're still seeing a real limitation in who can be tested. And the reason for that is that these clinical laboratories that are normally performing tests for viruses are not used to doing things like PCR as well. So similar to the state labs having a low throughput, the clinical labs really, you don't often have people in a microbiology laboratory in a clinic or hospital actually sitting there and pipetting into individual PCR plates. This is a level of expertise that most clinical microbiology labs don't have much expertise in doing. And instead, we generally rely on these what we call sample to answer test kits. These are tests that are made by like Roche and Hologic and QIAGEN and Cepheid GeneXpert. These are kind of like cartridge-based assays, or very simple to use assays where you load a sample on and you pop a cartridge into a machine and it gives you a real-time PCR answer. And that's what we would like. That's sort of the bread and butter of clinical laboratories. But unfortunately, those are highly, highly manufactured kits. And so that's kind of what most clinical laboratories in this country have been waiting on, is for these kits to become available. And some people might have seen the news a few days ago or last week, that Trump and Roche sort of jointly announced that Roche Diagnostics, the largest diagnostic manufacturer in the world, is coming out with a new test, and it has gained FDA approval to use it. Unfortunately, what we're finding, and that announcement came with a lot of fanfare about how many tests we're going to be able to immediately roll out in the United States. What we're finding, unfortunately, is that much of the rhetoric is falling flat. And that's because Roche, there's two things. Roche is a Swedish company, and they are certainly prioritizing Europe in terms of their reagent allocation and their kit manufacturing, but also they are prioritizing hotspots in the United States. So a lot of cities, including Boston, that want to use these Roche assays, which are very high throughput. If you have one of these machines, and they're sort of huge machines, like this, bigger than a big dining room table. So if a laboratory has one of them, they could maybe do 500 tests a day or so, up to 1,000 perhaps. But what we're finding is even places with these instruments already on board cannot actually obtain the reagents because they're going elsewhere. And so unfortunately, we're still finding ourselves in a position where people in the United States are wanting to be tested, but still are unable to go to the physician and actually get a test, even if they feel symptomatic. The triaging is still happening in very, very limited manners. Other hopes for tests besides Roche have been Hologic. They are a very well-known company that makes high throughput diagnostics. And unfortunately, they got their EUA yesterday, so they can technically start selling their assays to the country and to the world. But unfortunately, they won't actually have the manufacturing capacity up and running for about another month. And this is kind of what was, in my perspective, expected the whole time. You have to always take what industry says with a grain of salt. But unfortunately, it means that we, for the foreseeable future, still are going to maintain very, very limited testing. And we are seeing labs like LabCorp and Quest and ViraCorp, these massive industrial labs that have about 60% of the market share, so get online with testing. But even them, they still have pretty limited, in the low thousands of tests that they can do at a day. And they're sort of trying to do this for the country. So their testing is limited. And so to take a step back, a lot of people ask, how did South Korea do this? What made things so different? Why did South Korea get to quickly ramp up to doing tens of thousands of tests per day, given that they're in a population of 50 million versus us, we're 320 million? And one of the major limitations, I think, in the US is that our society is pretty fragmented. We are a very individualistic society. But we're a country that each state is given wide latitude to perform its own tests. And in general, as we all know, healthcare is generally privatized into individual companies and hospitals. And so what this really did was it more or less entirely inhibits any sort of leveraging economy of scale and sort of you can imagine China and Hubei province, they essentially just recruited huge numbers of nurses and laboratory technicians and brought in instruments, these 96 well plate type of instruments from around the country probably, and were able to scale up their diagnostics in a few locations in the country. And South Korea did something very similar. They also did things like GPS tracking of individuals who are sick, so it helped them get the epidemic under control. In the US, though, we really have I think we're seeing the limitations of having a fragmented society that sort of has a lot of states' rights and sort of limits or fragments healthcare into private industry, where at a moment of crisis when we really need to band together, there's no clear mechanism or pipeline to actually make that happen. And this is becoming acutely apparent in the testing world, where the ideal situation is we are able to leverage the efficiencies of different industries to be able to, for example, accession samples in very high throughput, tens of thousands or hundreds of thousands of samples a day using some automated instrumentation that one company might bring to the table, and testing facilities that another company might bring to the table. But we don't really have any mechanism in place to make that work. Even amongst hospitals that are in the same hospital group, we can't really make that work very well. And this has really become problematic, I think, and the issues that we're seeing in terms of testing really stem from this sort of fragmented approach to healthcare with no universal sort of cohesiveness. And so in terms of where we're at now, so I think I mentioned now that the industries are going to continue being lacking in testing, being able to at least shoulder, maybe tens of thousands of samples, but my estimation is that we should really be able to get up to around 100,000 samples per day for this country optimally. That would be the optimal. I don't think we'll get there anytime soon. Hospitals are going to continue being very strained for being able to do their own testing. So I can give one example of what we're doing here in Boston to try to make things better. So using our hospital infrastructure, I was only really able to get a test cobbled together through really massive efforts and a great team at Brigham and Women's Hospital, for example, to get about 50 to 100 tests per day available to our patients. And those are having to be triaged to the most urgent cases. But instead, one of the approaches that we're taking is I came across the city away from the hospital setting, and I'm sitting at the Broad Institute, which is where I also do some of my research. And this is an institute that has some of this large automation. They are not normally in the business of performing clinical testing for patients in hospitals. They do, however, have a CLIA certified laboratory, which is the type of lab you need to do clinical tests. And so working together as a big team here, we've essentially got roboticists and automated manufacturers and automated instruments and molecular biologists to all come together and essentially build what is looking more and more like a pretty robust pipeline to be able to do high throughput testing right here in Boston in sort of a hospital or healthcare system agnostic manner. So we won't be tied into any particular hospital, but we will just start getting things ramped up and accept specimens from the state laboratory or from hospitals across the state and hopefully from Vermont, New Hampshire, and Maine north of us. And I think that this is an approach that works. It might not be relative to the need in the country, it might only be a few percentage points of what we actually need to be processing for the country. But I think that these are the kinds of creative pipelines that we're starting to see pop up around the country to fill this void, if you will, and try to understand how we can get people to be able to be tested more appropriately. And that's kind of where we are. So I figure people have a lot of questions both about the epidemiology and the testing, and I just spoke for far too long about testing. But since it's so frequently in the media, I thought people would want some bit of understanding. So I'm going to open it up to people just to ask any questions they might want about either what we know about the virus, what the epidemiology of the virus, testing surrounding it, and whatever you might want to ask.
Thanks, Michael. Let's try to do the questions through the chat line, just so we don't have a lot of people talking on top of each other.
I think we can also I think Todd could potentially there's some way to like have people raise their digital hands, I thought, and then ask a question, but I'm not sure if you guys don't know how to do that, then I think that we don't have to bother with that. But then you could kind of unmute people one at a time if that was the case. I don't see the little digital hands here though, so maybe.
Yeah, I'm not sure if that's WebEx or a different one, and I don't see a quick button.
Yeah.
I have the list. One question to get started is they start typing them in. What about when you've got different tests from different places, how do they like their sensitivity, specificity? Do you get a range on that, or is that kind of controlled through the approval process?
Well, so we don't really have to this day, we still don't really have a good sensitivity and specificity metric for these tests. Certainly the greatest variant, we're seeing that the specificity is very high.
Right.
With the exception of that N3 primer that the CDC ultimately removed. We're also seeing that it does appear at the true sort of test level, we're seeing that it's very, very sensitive, and we're able to pick up 1 copy per microliter or even 1 copy per specimen aliquot. And so it's very, very sensitive, but certainly the greatest source of variation is the specimen type. And these are primarily nasal swabs now. We're starting to see major limitations on on what's available to actually do the testing. So now it's no longer even the test itself, but it's actually the availability of swabs and transport media and all of these things. And so all the testing is hopefully going in the direction of just using nasopharyngeal swabs. But that is sort of famously prone to a lot of sources of error, if you will. And so I think that's where we lose real sensitivity. And probably if the correct study was really performed, we would see, my guess is that the swabs lead to around a 70 or 80% sensitivity, at least for low viral patients.
One of the questions that came in is, have you read the Imperial College report, and what are your reactions to that?
I've been reading a lot from Imperial. Which report? There's been a.
I think the one yesterday is probably the one that we're referring to, the
herd immunity.
Yeah.
So I didn't actually read the report itself, but I can speak towards the idea of the UK's approach to herd immunity as the solution versus other approaches. In general, I think the idea of trying to control this virus at a population level through the development of natural herd immunity is a horrible idea. It doesn't make sense for so many reasons, but our healthcare systems, in particular the NHS, but also the US healthcare system and many others, is already sort of stretched to the seams on any normal day. We have extremely limited numbers of ICU beds. Usually we're just at equilibrium. So any sort of spike in demand for these types of resources is going to absolutely crush a healthcare system today. And the NHS certainly has very little bandwidth to expand itself.
Mm-hmm.
The rest of the world is not China. We can't just make 2 huge massive hospitals in 2 weeks. We can rent out big hotels, I suppose, and do that. But I think that was a pretty poor decision, and I'm not quite sure where it's at right now. I think that there's some backtracking going on with that decision, but it really has the potential to cause some serious damage to the healthcare system and patient care.
Okay. There's a group out of Seattle that's been doing surveillance of viruses circulating in the community, which had an assay running quickly for COVID-19. So many of us probably saw this in the news. They didn't have FDA approval to share results with patients and so on. What are your thoughts? Is that a group you're in contact with, or?
Are you talking about Alex's group doing or is this I
think this was the ongoing flu study, Seattle flu study.
Oh, yeah. So, I mean, I think we've been discussing this exact same issue here, and there is, in particular for using non-FDA approved tests, from a public health perspective, I think it's absolutely essential that we try to get screening out as quickly as possible. I think that it shouldn't be too difficult to validate these tests at this point. There's sufficient samples, especially in Seattle, that the test should be able to be validated. If they work, they should be able to get FDA approval very quickly and share those results back with patients. So I'm not sure why they're running into that issue of not being able to share them back. But the real question being, what's the role of public health versus individual health? And if in the situation where you can't share results back, it's something we struggle with a lot. Do we want to sort of spin up, before we got FDA approval to sort of start doing testing here, for example, the question was, should we actually just do this as a public health measure to know the transmission and just start screening people off the street? But ultimately, I think the clinician in me started to get very, very uncomfortable with that idea of knowing a positive result and feeling some ethical obligation to get those results back to somebody. And so it is this constant tension between public health needs versus clinical needs. And I would hope that instead that we would be able to figure out some way to get those results back. And there's a lot of companies now working with Google, this company Color, and a few others that are able to really quickly and using sort of digital mobile software get results back to individuals if they're tested. And I think that's the way we should all be thinking, to really bridge the two, public health and individual health scenarios.
Yeah, that tension's important, actually, the part related to the theme of this class about different scales, because there's different reasons for tests. There's the test for, do I have the disease, or does my patient have the disease? And then there's the test of the population numbers. What is the current prevalence? What's the current case count? So on.
Yeah, and
Um,
right now we are, I mean, from a public health perspective, just to like step back, I've had a lot of people say, why are we testing anymore? We're assuming, like, what's so important about testing? The real need for testing at this point is we need to know if our interventions are working. We have at this moment in time, we have no idea where we are in the curve, and by not knowing where we are in this epidemic curve, we also have no idea if we're turning over the curve. And this is going to continue being a really serious issue for us, I think, to not have now that we're making these amazing social changes, and they're being put together by the governors and senators and university presidents and whatnot. The biggest questions today are, to what end? How long does this continue for? And that's an extremely difficult question to ask or to answer if we don't know where we are in this curve. And so it's yeah.
so I have a question on warmer weather affecting potential spread. Seems like tropic countries are also experiencing a lot of cases. Thoughts on that?
Yeah, I mean, we've seen lots of cases. Still, that's an open question. We've seen lots of cases in warmer countries so far. So there's not any, I would say that there's no good evidence one way or the other. I think the force of infection and the just sheer number of susceptible people will probably outcompete any seasonal effects. But in particular, since we're seeing that it can obviously spread in warmer climates, so I think that might end up being a limited mitigating factor as the warmer months roll in. But we can hope it will, at the very least, maybe reduce severity of disease. For example, if some of the severity is more pronounced, for example, for people who have drier secretions and mucosal membranes, there is some reason to believe that that are in moister climates and humidity might, even if it's not necessarily decreasing transmissibility, it might decrease severity in some individuals.
Okay. How about asymptomatics? There's a couple of comments, just proportion of cases, contribution to transmission, thoughts from you and the immunology perspective.
Yeah, I think that we've certainly seen that children can carry, so let's take children, they're often asymptomatic. We're seeing that they're able to carry this virus, and they're in contact tracing in Singapore and in southern China. We're seeing that younger individuals who are largely asymptomatic actually have carriage rates of the virus that are pretty similar to people in their 30s and 40s. It does start to increase in terms of both carriage and severity of symptoms beyond that. But I think some of our modeling efforts here, where we're using different contact matrices and we're essentially asking questions like how crazy does adult contact mixing have to be in order to get the type of transmissibility we're seeing and the spread that we're seeing. I think that the evidence is largely pointing to at least some contribution of asymptomatics and of very mild symptomatics towards transmission chains. And some more recent data is more or less pinning this down. In fact, Biogen here in Boston had a conference, which at least it's been in the news here a lot, and hundreds of people are now infected or presumed infected who are family members and others, but very, very few of them have demonstrated any symptoms that have been reported. And I think that it's conferences like this that are really showing that this virus can very likely transmit through asymptomatic people, whether that's through surfaces or secretions in coughs and whatnot. If you're coughing, you're symptomatic. So it would have to be some other sort of more mild transmission.
What's the likelihood of repeat infection? And
yeah, so that there was a few papers or case reports really early on, or really early, I mean, it feels like months ago that all this that showed that people were people who had already cleared the virus were showing up as positive again, and that led to a lot of confusion. My personal feeling is that these people are not necessarily getting reinfected, at least with any symptoms. More likely than not, these are nucleic acid tests. And we know from measles, we know from a lot of viruses that far after you clear the infection and are no longer transmissible, you actually still can have RNA or DNA detected using PCR-based approaches. Doesn't necessarily mean that the virus is viable or replicating. necessarily. And I'm guessing that that's really what led to some of those earlier reports of sort of people coming up positive a second time. However, we also know that this is a coronavirus. It's probably not a sterilizing immunity type of virus like measles or polio. And so maybe not in the first few weeks or a couple months after infection, but maybe a year later, we will end up seeing potential re-exposure. And we see that, for example, we see signals when in our modeling efforts looking at seasonal coronaviruses and the way that they have the seasonal patterns that each of those strains have. We do see some evidence that suggests that probably immunity is only partial and may wane over a year or so. My hope, however, is that if that's the case with this, we might end up seeing, if people do get exposed and infected a second time in a year, for example, that their infection severity would be significantly more limited. And of course, the vast majority, I think I didn't make it clear before, that the vast majority of people who are likely getting this virus are probably very, very mildly symptomatic or entirely asymptomatic in the first place. Probably the mortality rates, for example, are at least 10 times lower, or 10% of what the reported ones actually are currently in, like the 3%. My guess is it's more like 0.3%. Mm-hmm. And there's some reasons that's not just pulled out of thin air. Right. And so I think that, all of that combined, I think that hopefully, even if people are getting exposed a second time and infected a second time, it will be much more mild.
Okay, I've got kind of two more questions, and you wanted to wrap up around 12:45. So the first is, what kind of coverage and testing would we need to attain in order to feel like we have adequate estimate of the actual burden of disease? What you've talked about capacity. If capacity were not an issue, where would you like to see this going?
Yeah, I think that, my feeling is we would want to get somewhere around like 5% or so of the population tested over the next 2 or 3 months. And I think that's still not a huge percent, but I think it would be a lot to give us a good sample size in terms of estimation of burden and prevalence. And so if that's over a few months, I think that probably getting up to 100 or 150,000 tests per day would be particularly useful. But we're getting to a point where I think actually the most useful tests are going to be serological tests, where we have such limited testing that we're really passing this window of the early stages of this curve. And I think getting into serological testing will start to become the much more informative test for us. In particular, as we're starting to self-isolate and not go to work, we would really like to know how many people have actually already been exposed, that we can bring them back into the workforce or into the school system. So I think combined, though, I think 5% would be sort of what I would feel would be really useful to actually get. Okay. And that's what South Korea really, if you look at the actual testing that was performed in Daegu in South Korea, which is the city where the major outbreak was, just south of Seoul, they're testing over just a 20-day period. They were able to test about 4 or 5% of their population, and that helped them get that under control.
Okay. The last question has 2 parts, or 2 scales anyway. It's your thoughts on best long-term strategy for control, and then also how would you advise your colleagues here on making the best choice for their family and so on, in terms of kids are home from school and college.
Yeah. Well,
what's magic about 10 people?
I think, as far as the family units go and things, I think truly the best approach right now is to stay home and actually just weather the storm. I think the decisions by universities were very good. I was on the president's advisory board here to recommend that Harvard close the school and send students home after spring break. And I think that was absolutely necessary. But now comes the hard part. It's like, well, what do we do now that everyone's home? And this is a seriously difficult question. I've been, over the last my life has like seriously turned upside down in the last couple of months. And I've been talking to like CEO of Goldman Sachs and all this stuff about these questions, because they have, there's trillions and trillions of dollars on the line for understanding, what is the economy doing. And we really don't know. I mean, the unfortunate piece here is that the better off we are, the better we are at this point in time at prioritizing not ripping the seams of the healthcare system and flattening this curve to preserve our healthcare system, we run the serious risk of economic collapse, and we're seeing it already. I mean, the servers in restaurants are how will they stay open? Many of them run the risk of going bankrupt. The lower economic state population in our country is going to, of course, feel this by far the worst, and that just has massive consequences everywhere. So we really need to figure out, okay, if we're going to be stretching out this epidemic as long as possible by flattening this curve and through social distancing, which I fully support. I don't know what kind of stimulus has to be provided concurrently to maintain people's ability to thrive, and the longer we stretch it out, the longer we have to keep them away. And my hope, though, is that what will happen is we'll be able to thin this curve out so much that we can ultimately start really getting back. We can get things under control sufficiently over the next 2 months, so that as people start to return to work, we can start testing them as we probably should have been 2 months ago. We can start testing the population, have people go back to work, and start doing really targeted and very stringent epidemiological tracing and approaches to mitigate small outbreaks as they start to ramp up again once people go back to normal existence. That's I think the way that we'll have to really tackle this, because we're still going to the more this all works in terms of social distancing, we might end up in a couple of months from now having 1% or less of the population having been exposed, and so we're really not going to have any population immunity. So we'll have to figure out how to deal with it.
Right. Well, we want to thank you. I didn't give the thanks from every person who wrote in here, but almost every one of these really appreciates your time and your insight. I know you're very busy in your, as you said, your upside down world. But we appreciate you, honoring your promise to talk to our class, although when it started, you probably weren't expecting the current situation. We're excited about the work you're doing, and want to thank you very much for your time.
Absolutely. It's nice to talk to everyone. And if you ever do want to hear about measles, I'm happy to come back at a time when it's a little bit less crazy for all of us, I think. So
yeah, I think we'll keep that in mind. I'm sure, and here's hoping that comes sooner rather than later.
Yeah.
So Michael, thanks very much. Keep up the good work, and thanks for everyone for tuning in today.
Yeah. Thanks everyone.